Hello and welcome in today's nursing webinar session. Myself Shanti, and we are going to talk about the pneumonia and its serious consequences. So let me welcome our expert panelist, Dr. Kishan Garu, who is our senior consultant, interventional pulmonologist and critical care specialist from Yashoda Hospitals, Secunderabad unit. Sir, unmute yourself and I welcome you, sir. Unmute yourself, sir. And let me also welcome the Senior Nurse Manager, Rashmi, who is from ACU unit, and I welcome you, Rashmi. So, sir, we would just like to understand, you can start sharing the slide, Rashmi. So,
Yes.
since this is the topic about management of pneumonia and LRTI, and this cannot be just spoken in half an hour of time. So, can you please share your insight on the current state and impact of this condition, sir, or this infection? Because many school leaves and even the employees, sometimes we get to procure a leave because of the respiratory condition. So, what is your take, short message on this? Sir, unmute yourself, sir. Yes, sir.
Hi, good afternoon. Thank you, Shanti, for the kind introduction, and also welcome Rashmi for this webinar.
Thank you, sir.
If you ask me about pneumonia as a broad, is a very broad term. So we have different. I hope Rashmi is working in intensive care or in the wards.
Yeah, sir. I'm working in an MCU, sir.
So in the intensive care, so we broadly classify pneumonias based on the type of pneumonias, like what we call as community-acquired pneumonias.
Yes, sir.
Sometimes we call it as hospital-acquired or ventilator-associated pneumonias. Previously, there used to be a very broad classification called healthcare-associated pneumonias, where for people who are working in healthcare settings and all. So it's a very major problem, especially in patients who are elderly age group patients, like more than 65 is what is the high risk group of patients for acquiring community acquired pneumonias, especially. And if you see the incidence of community acquired pneumonia, especially in the states, I don't think in India we have a clear statistical data on how much is the incidence. But it will be like for more than 65 years of age group adults, like 2000 per 1 lakh population is the current incidence of pneumonia. So what is important for the nursing, especially when it comes to in the intensive care setups, is like you should be aware of what kind of organisms are prevalent in our hospital setting, because being a tertiary care hospital, most of the patients are transferred from peripheral center where they're already admitted in a hospital. So we don't see very classical community acquired pneumonias coming to the outpatient clinics in our hospital. Mostly we see hospital acquired or superadded infections following an infection episode. So that is my view with my experience in our hospital. So you will be seeing most of the patients coming for a ventilatory support in the ICU, or patients who are requiring oxygen. So that group falls under patients who are pneumonia with who require hospitalization.
Okay.
So again, if you classify based on their symptoms, we classify pneumonia into patients who can be treated on an outpatient basis and patients who should be treated on a ward, or patients who should be treated in a hospital intensive care setting. So based on certain scores, I think you will be explaining on how you manage those patients. We will take it forward. So you can continue with your lecture, and then I'll keep adding
Yes,
my points in between.
definitely, yes, sir. And Rashmi, the session is over to you, and we will just intermittently talk. Yes.
Thank you, ma'am. I'm myself Rashmi. I'll just forward with the slides, ma'am. As we see, not many cases of pneumonia and LRTIs have been coming in ICUs. We got to know what it is. Pneumonia. Pneumonia is an inflammation and infection related to air sacs and the alveoli. But in LRTI or URTI, it can include with the bronchioles, trachea, all the upper respiratory as well as with the lower respiratory tract infections, it will be included.
So can you share the slide just now what you've spoken?
Yes. Okay.
So sir, again, here we just get to see the nurses who are in the ICU setup. I mean, they do not know the difference between, whenever you ask, they keep saying that it is a case of URTI and LRTI. You know? So how does it differ, sir? And what nurses should say? I mean, I know, the LRTI and URTI is affected part के अनुसार only we just say. So what is your take on this, sir? Because we also have a
So
fresher nurse.
usually, when we say pneumonia, that means already the pulmonary lower respiratory tract infection has already occurred. So we don't call pneumonia for patients who have an infection that is confined only to the larynx or pharyngeal area, especially the upper respiratory tract. So the term pneumonia is mainly to those patients who already have a lung infection, especially those patients on X-ray, you will be able to find some sort of infection. As you see on the left side, you have a patient with the right mid-zone. Radiologically, we call this a consolidation, but the clinical term for that is pneumonia. So upper respiratory tract infections usually present with symptoms of cough, running nose, or both lower and upper respiratory can have presentation of fever. So you need to, but as an ICU nurse, you will not be seeing more of upper respiratory tract infections. It will be once the patients go into the lower respiratory tract infection only, you get those patients in the ICU for management.
Yes.
Yes, ma'am.
So again, this is how whenever we see nurses presenting the case and, when it is asked, we request all the nurses to just go through the case details as it is very much very well documented by the consultant and the team. If it is LRTI, where what happens, what is happening with the radiological imaging, what happens with the HRCT, as sir said, we are supposed to use like consolidation, infiltrations, all that, not to just vaguely say LRTI or URTI. So nurses and learners, please make this correction and just improve your knowledge upon. Thank you.
And
Yes,
also, when you are the people who will be seeing the X-rays that are done in the night time, so you
yes,
should know a little familiar terms like if you talk on radiology and then dividing pneumonias, so we call it as lobar consolidation. Means lobar consolidation means it is confined to one single lobe. As you know, right lung is divided into three lobes: upper, middle, and the lower lobe. The left lung is divided into left upper lobe and the left lower lobe. So it is very important to know this. Why? Because there are certain organisms, means you can come to a clear differential diagnosis what the patient can have. Like certain organisms will have predilection to have lobar pneumonia. The other one is bronchopneumonia. So means you have multiple areas of infection you see which can spread through the bronchus. And again, in the radiology, again, you can say it as sometimes we see nodular pneumonias, especially in fungal infections. So there you don't see this whiteout shadows on the chest X-ray. There you see small nodule-like changes, patients presenting with fever or hypotension. So that can be a suspicion for fungal nodular pneumonias. So these type of because when we come for rounds, it will be easy for us to understand when you say that patient has consolidation in the right upper lobe, upper zone or mid zone or lower zone, or the patient is having a lobar consolidation, or the patient is having a multilobar consolidation, different segments or different lobes getting involved. So these are the basic small terms that will help the clinicians to fasten their rounds, and then you also will get an understanding on the radiology of the infection and what are the probable, and that also helps you to make yourself when, because you are very close in contact with the patients, right, every day. So when they cough on you, what precautions you should take, especially India being a very high burden country for tuberculosis, you can see this lobar consolidation patterns, especially in the right upper lobe, sometimes presenting with respiratory failure also. So you should understand that this could be probably a case of tuberculosis, and we have to isolate them as early as possible so that the other patients do not get infection. So what you see in a consolidation in TB patients is usually you see some upper lobe is more predominant involvement, and also you see some cavitary lesions like a hole in the chest X-ray. Those things you should be little familiar when you make an initial assessment of these patients.
so very well explained, sir. And I think Rashmi, you will also carry this point and try to train and teach your nurses because, as sir said, anatomical location, but we are supposed to say it is not that we just say ki bronchopneumonia and we are just saying it as a pneumonia. And whenever there is high HRCT imaging and radiological impression, we are supposed to just read and present well so that we also gain the competency. And as sir said, they can just fasten up their rounds. Yes. So yeah, carry forward
Yes.
again. Yeah.
Yeah. Thank you, ma'am. So now we are going forward with the potential causes of inflammation, like bacterial, viral, fungal, parasitic, aspirational, seasonal or environmental, which triggers with the causes of pneumonia.
So I think, sir, we also get to see sometimes when we read the history and all, like these are the seasonal and environmental triggers which happens mostly. So would you like to just give us a little bit insight on this scene?
So if you broadly classify these pneumonias based on their etiology, most common usually will be bacterial pneumonias. Of all the bacterial pneumonias, streptococcal pneumonias are the most common infection what we see. But again, if you talk on a community-acquired setting, streptococcal pneumonias are very common. But if you talk in an ICU setting, already these patients have some time from one hospital to the other hospital. There, we usually in our hospital incidents, hardly I think we have seen 5 or 6 patients last month with streptococcal infections. So we see more of MDR infections because they are hospital-acquired infections. Patients we receive them, and some other bacteria which can commonly cause pneumonia is H influenza, staph infections also we see, Moraxella and other bacterial infections. And what you should understand here, because when this is very important for you from the nursing aspect, even before we doctors come for rounds, if you see that the patient is expectorating, you give him a sterile cup and send it for culture, because early morning samples yield more bacilli. So it is advisable. So you don't have to wait for an order to send a sputum culture, especially when you feel that the patient is having a community acquired or a hospital acquired pneumonia who is requiring oxygen and all. So it is very important to collect specimens as early as possible so that we can start on appropriate antibiotics. Why I am telling this is deterioration in pneumonia happens very fast. And if we miss that period where we can get a proper lower respiratory tract sample, sometimes patients go on a ventilator and then you have to do an invasive procedure like bronchoscopy. So if you have a proper sampling and then you know based on your gram stain, you can just try to avoid unnecessary antibiotics, and you can show that okay sir, this patient is having a GPC or a GNB, and empirically in the night, if the patient is coming in the night, we have started him on both GPC and GNB. I think we can omit one of the um, drugs and then try to decrease not only the financial burden on the patient but also avoid resistant patterns for these kind of infections.
Yes.
So, and if you come on atypical infections, these are very difficult to understand because the radiology of atypical pneumonias is very unfamiliar to all of us. They don't present like a large consolidations. They'll be usually small patchy consolidations involving both the lobes, both the sides of the lungs, like right and left. And most common organisms will be Mycoplasma pneumonias. We do see Mycoplasma infections in our hospital also, with who come to ICU, and some chlamydial or Legionella infections. These are also very common. And as we are very familiar after this COVID pandemic, viral infections. So we can sometimes have a mix of patients who have a viral infection and then who has a secondary bacterial infection also. So in knowing those and trying to protect, especially from these infections like COVID and influenza infections during the nursing care is very important. And alerting the doctors or the nursing in charges to isolate them as quickly as possible if you feel that the patient is having because if you find the report sometime when the doctor is not available and you see that okay, the patient is diagnosed with influenza, so quick isolation is very important in these patients so that the infection doesn't spread to other patients.
Yes.
Yes.
Yeah.
There are some more other causes and factors which will be affecting with the pneumonia, like the age factor, which below 2 years, as sir told, above 65 years, which is a immunocompromised age group, patients who are having heavy smoking, weak immunity, chronic systemic diseases like COPD, cystic fibrosis, interstitial lung diseases, prolonged hospitalization like in ICU admission, staying the patients for more than 10 days, proning for get hospital acquired infections, patients with malnutrition, etc.
So, sir, right from the COVID time, we are hearing this weak immunity, and the malnutrition factors and prolonged hospitalization. Like these infections are also deteriorated if the individual has a weak immunity as well, if at all.
So again, immunity is a very broad term when you're talking on infection. So if you talk on community-acquired pneumonia, age is the predominant risk factor. Risk factor in the sense more than 65 years of age group stands as the highest risk factor for any patient who can develop pneumonias. And if you see the this figure means it is approximately like three times higher than in general population. This age group will get pneumonias. So on an average, like 2% of these elderly age group population can develop community acquired pneumonias. This is major risk factor, and other conditions like chronic respiratory illnesses like asthma, COPD, who have active history of smoking, patients who come to dialysis units regularly, and then they can acquire very quick infections from the hospitals. Patients with risk of impaired airway protection, like those patients who have history of neurological injuries or trauma, these patients are also at risk of developing certain types of infections, especially aspiration pneumonias and all these things. So it basically the risk factors and causes, if you see that they depend on what type of patients we are dealing with. So immunity, as you said, elderly age group. So we'll talk more scientifically that elderly age group more than 65. These are the patients who can come to the ICUs with a very bad pneumonias.
Though there are some mimic symptoms, but the severity as well as the combination of symptoms will be varying according to the patients to patient. Some of the symptoms we can see like the cough, which might be purulent, some might be mucoid. There may be fever, they might not be with chills, SOB, fatigue, wheezing sounds on auscultation, nausea and vomiting as the patient will be having continuous cough, diarrhea, and severe state of uh, RDS, respiratory distress.
So again, when we talk about the respiratory infection, we get to see many population normally, they just manage something by taking OTC at home unless until symptoms worsens, then they, seek your help. So what is your, cautionary message you would like to give to them?
So the problem with the symptoms of pneumonia is whether it is a bacterial pneumonia or a viral pneumonia. Most of the pneumonia share the common symptoms, like usually patient present with cough, expectoration, sputum production, which can become purulent after 2 or 3 days, and then most of them might run fever. So it is very difficult to differentiate based on these symptoms whether the patient is having an active viral infection or a bacterial infection. So these are the areas where if you focus on taking a proper history, like usually viral infections are spread through very fast. Like if you ask them whether some of the family members have the similar episodes, what is the season the patients are admitting with infections, because viral infections happen in certain period. So these are certain basic things. Symptoms, as she rightly mentioned, that most of these symptoms are common with most of the respiratory diseases. So you cannot pinpoint that, okay, this is this pneumonia based on these symptoms. But when you talk on expectoration, there are certain conditions like if you see greenish expectoration, it is common with some organisms, or if you have a brownish expectoration or a hemoptysis like pneumonias, false hemoptysis is what we call, especially in patients who have serratia kind of infections, they can present with hemoptysis. That doesn't mean that normal community acquired pneumonia also can present hemoptysis as a symptom. One other thing we should not forget in pneumonias is some of the patients present with acute pleuritic chest pain. So chest pain also is a very important thing to be considered in pneumonias, and it is sometimes very sharp. For these patients complain that there is pain in the chest. So you should make a clinical judgment, not to run all the tests for cardiology, but you can understand that, okay, this is a pleurisy or pleuritic chest pain based on his radiological pattern of involvement. So these are the usual symptoms what we come across in pneumonias of all kinds, whether it is bacterial, viral, or fungal infections.
Yes. Yes.
And if you run the test, I think you have a separate slide for that. Yeah.
Yes, yes.
Yes, yes, sir, sure. Yeah, as you said, so, sir, as nurses, we are the first ones to have an initial assessment, and our care starts from there itself. We have to assess the patient, we have to assess the history, collecting with the history of traveling, with the history of allergens, and we have to see for the maintaining with the airways, for asking for the airway compromisation. We have to, after the all history collections, we'll go forward with the blood investigations like common hemogram, procalcitonin, CRPs or viral markers, going ahead with the chest X-rays, HRCTs, assisting for the bronchoscopy, then following with the ABGs to check on with the O2 levels and the CO2 levels, like for that.
So, sorry,
Then we
yes, like as on your rounds, you usually see any other such lapses you would like to tell in this forum, sir, like, how to check on, like ABG, sometimes it comes with the severe respiratory acidosis and severe proning and then respiratory distress. So any other points or anything which within this would like to tell us? We'll take the
So
badge.
initial assessment, you have rightly pointed out doing all this investigation. So what are the common things that get elevated in pneumonias? First is leukocytosis. Usually patients will have high white cell counts, especially if it is bacterial infections, and the other way around for the viral infections. So this is one thing. Running a procalcitonin in all the patients may not make sense because it is a very variable and a very high expensive test. I think we can rely on the white cell count, clinical symptoms, CRP, and other factors. These are the things that would rise initially. What, as a nurse in the ICU, should be very careful is, especially with these community acquired pneumonias, whether the patient is having hypertension, is he fluid responsive or not? Because the initial management of these patients, because especially when they start to have this septic shock, it is very important for us to draw blood cultures before you administer antibiotics. So draw two sets of blood cultures and send quickly to the laboratory, and then run a fluid challenge test and see if the patient is fluid responsive or not.
Yes.
So I think hypotension is something we should have a very good focus on. And the moment you have like a patient who is deteriorating with community acquired pneumonia, like starting from SIDS and then to sepsis and then shock, alerting the doctors to place lines, administering adequate, appropriate antibiotics once the cultures are drawn. So from this, I think is important. Bronchoscopy, definitely not for all the patients who present with pneumonia. As I told you, a good sputum sample from the lower respiratory tract is very important. But in case patients are ventilated, where not only for at the initial presentation, but after some days, if the patient develops a new infiltrate on the next ray, like the definitions, like I hope you know that healthcare hospital acquired pneumonia means patients who develop pneumonia after 48 hours of hospital admission, and ventilator associated pneumonia is after 48 hours of endotracheal tube intubation. So if you see that there are new shadows coming or new clinical symptoms or a new hypotension that is setting up or a rise in TLC, when we feel that, okay, we need to have a sample again. If the patient, first we need to assess the stability of the patient. If the patient is stable, we go and do a bronchoscopic lavage or a bronchial toilet and then get the sampling, or sometimes a mini ball or an ET secretions also can help you in getting a proper sample. So especially when you're doing this mini ball and uh, protective specimen samples, it is very important for you not to contaminate the sample. It's very important. So bronchoscopy, not a routinely indicated thing for pneumonia, but sometimes when you don't have an answer, definitely yes, it plays a very important role. So these are the tests. And one more thing is, the moment the patient comes, there are certain scores that decide the 30-day mortality of patients and the severity of illness. So previously we used to take CURB 65 as a scoring index, but now we have the pneumonia severity index. So it's a lot many parameters. So try to fill in the PSI form before the patient doctor comes in, and then see what class of PSI the patient has, so that we can have an estimate on the prognosis of the patient also.
So yes, we will take the correction as you rightly said, sets of blood culture and sputum collection is always mandate. So yes, next slide.
Yes, following with the management means the nursing care, we have to maintain with the airway patency, the oxygen therapy required for the patient, checking for the allergic status, positioning the patient semi-foulers or the foulers for to draining out the discharges, any hydration, monitoring with the vital parameters, especially regarding with the heart rate, the saturation levels with the BP, spirometry, and chest physiotherapy, which is all and foremost important equally, proning the patient when required, and the oral care, because we are giving with the steroid, we have to follow with the oral care for the patient.
So, sir, when we are talking about the oral care, I know we are sometimes we still, give corticosteroid inhalation, and oral hygiene is not being provided, and suddenly we see oral thrush when the patients are shifted from ward to the ICU. So, would you also like to just give some precaution messages to the nurses?
So in pneumonias, the use of corticosteroids, especially, we don't use routinely for all the patients, but patients who are having septic shock, it's a very low dose of septic dose of corticosteroids we see. But we see this problem of oral thrush in patients who are already on a very long, especially those connective tissue or rheumatology related diseases who are on chronic immunosuppression drugs, and then we give steroids and then they develop this oral thrush and all. I think it is a very clearly mentioned measures how to prevent all these hospital or ventilator acquired pneumonia. So keeping the patient position in a certain angle, doing oral care, prevention of aspiration measures, all these things will, I think it should be a routine checklist for you in the ICU, so that you try to, means these are something which we cannot come and tell on daily basis, right? So you have to have a checklist for yourself and see, especially again, the cuff pressures,
Yes.
ET cuff pressures, if the respiratory therapist is not around. These are the things that you should check and then highlight to prevent any hospital related infections, or as you said, chronic steroid usage can cause sometimes oral that. So oral care also becomes a very important um, care in preventing risk of means progression of pneumonias in these patients.
Yes. You can quickly shift off. Yes.
The treatment based, as already Dr. Sir has described, regarding the antibiotics, antivirals, antipyretics, nebs, which will be included with the bronchodilators, mucolytics, steroids, hypotonic solutions for the nebulizations, steroids, cough expectorants, but not the least with the vitamins to ensure with the patient's immunity.
I think these are the prescribed as per the condition of the
And
patient.
most commonly, what we see is like sometimes patient is having an active expectoration, and you see the prescriptions, sometimes there will be cough suppressants when the patient is having active expectoration. So that is something you should make a note of and highlight, because you should not suppress the cough when the patient is having expectoration. So that is one thing. And basic management is, you should be knowing what is the predominant infections in our ICU, the antibiotics of the ICU, means our antibiogram, and then based on that we have to select the antibiotics. So in this you have mentioned all the baseline management for respiratory infections, but the management mainly with pneumonias depends on the antibiotics of proper choice. So there should not be over usage of empirical antibiotics, and we should guide the antibiotics properly based on the organisms. And also you see, you have now the rapid multiplex PCRs like the film array panels and all. Though the turnaround time for them is very less. So you should, if the patient you feel that is a high risk patient, sending them and then getting appropriate results in 40 minutes makes sense. And I think what are you trying to tell from this slide?
Like we are just trying to show these are the classification of the medications which somebody should be a little careful on. As you said, when patient is trying to expectorate, we are not supposed to suppress the cough. So this is a just common general slides. Yeah.
Yes. So treatment mainly is around antibiotic therapy, proper antibiotic therapy, and these all are supportive care what we give for patients with not only pneumonia but all respiratory conditions.
Yes.
Yes,
Yeah.
sir.
So like
Addressing.
now
Yeah.
addressing myths about vaccines by clinical expert, like we would like to even hear from you, like uh, can this vaccine be
So
as a part of prophylaxis, prophylactic wise? Like
yes, because after COVID, what we see is most of our patients, they when we ask them, have you taken vaccine? They only remember COVID vaccines.
yes,
So we are not taking COVID vaccines now. Most importantly, what we see, because last 2 years we had a very bad influenza season. So influenza infection is very common, especially in our setup also, where we also have to take a regular annual influenza vaccination. So every year, all of us, irrespective of the risk factors, who are healthcare providers or work in an hospital setting, everybody should be encouraged to take influenza vaccines every year. And pneumococcal vaccine, we don't have the current available 20 and all, but we have the 13 and 23 vaccine. So 13 followed by 23 is the recommendation with a gap of around 8 weeks, what we see. So pneumococcal vaccination and also herpes vaccination is also currently recommended for patients who are more than 50 years of age group. So these are the three vaccines that we should address to elderly and also patients who are at high risk of developing pneumonias.
yes, yes, Rashmi.
Yes, ma'am. So now we will see with the preventive measures, as prevention is always better than cure. We have to visit the patient doctor, avoid with the over-the-counter drugs, stay indoor during the flu seasons, have proper hand wash, wearing of a proper PPs, especially with a mask, respiratory hygiene, cough etiquettes, avoiding for the tobaccos and smoking, avoiding to the exposures to the airborne irritants also.
So I think, sir, this you will also go with this slide that prevention part.
Yeah,
Yeah.
especially it has become very common that you see patients taking azithromycin for all
Yes.
infections, irrespective, because some of the conditions, some cardiac conditions get aggravated by taking these macrolides. So it is not recommended for anyone to take macrolides without having a proper doctor prescription. And you should not encourage over-the-counter medications. You should seek proper care from the medical specialty and then try to I think from the nursing aspect also, the moment you have an infection from the patient, you should try to isolate yourself and try to highlight it to the nursing staff that you have some infection, and then you should apply for a leave. And all those things also matter, because you cannot keep on working when the infection is around even with you. And well said, all these precautions, yes, we tell them, but most of the people, they don't practice this. So you should do some activities that promote vaccination education and practices.
The PP concept, everything is. You can come to the conclusion now, Rashmi. Yeah.
So after the discharge, we have to give some instructions. So following with the instructions, we have to limit the visitors to the patient, resume to the work as according to the doctor's advice. Minimal activities will be encouraged to the patient, take proper drugs as well as continue with their normal activities also.
Yeah, you can just go to conclusion, come to the conclusion, yes. So here
Con-
we have done our quick presentation. Now, would you like to conclude for all of us, like early detection
Yeah,
and
for the from the nursing perspective, it is very important to understand the basics of pneumonia, their presentation, and what is the common infections that we have in our ICUs or in our healthcare setting, and what are the commonly used antibiotics, and what is the resistant pattern for those antibiotics. These are certain things. And coming to nursing education on pneumonia, taking proper care while you nurse the patients, because these are infectious diseases mostly. So having proper PPE and all these things also is very important. And while looking at the radiology, as I told you, you should make a basic understanding what type of pneumonia this could be. And patient coming from outside hospitals on a ventilator, trying to prevent aspiration and all these risk factors, how to maintain properly those checklist you should maintain, and then proper scoring systems to know the severity of the patient. And when you talk on drugs also, it is very important to see that there are no drugs that are repeated. Like some checklist I see, sometimes the patient will have one name and the other name, both the drugs are the same, and then they both are being administered. So before you administer drug, you should know the proper content, what is there in the drug, and then try not to give the same drug again twice. It can happen in medical care settings that we see commonly, and assuring the patient that patient will become all right, and giving proper, because bedside care is also very important, and making them expectorate, getting the physiotherapy done, mobilizing them very early. These things will help you in preventing from progression of the disease, and identifying a tube block, tracheostomy blocks, or highlighting the doctors, especially in the night duties when patients have sudden desaturation episodes, fluid challenge in the initial setting, and collecting the blood before the antibiotics are administered for blood cultures, having scoring systems for all the patients the moment they come in the ICU. These are very important steps that you can help in uh, decreasing the burden on the healthcare workers. And coming to healthcare advice, you should, while discharging the patient, you should warn them what are the warning signs, red flags, what they should be aware of, and what medicines to take, and how they can, and if any problem is there. And also check the list of medications, because most of the times, if the patient is having some comorbid illness, and while the patient is getting discharged, those medications get missed in their charts. So if the patient has some previously used drugs for some other conditions, you should make sure that these drugs are also given at the time of discharge to continue. So not just concentrate on our medication and just find out what drugs they are using. These are the basic things I think the nursing should practice. And um, yes, and that's it from our side for the nursing
Yes.
team.
Thank you, sir, for the very quick core points which you have contributed in this session today. Thank you, Rashmi, and thank you. We end the session. Thank you so much.
Thank you.
Thank you.